Hello there, I'm Dr. Srishti Banerjee, Masters of Physiotherapy in Neurology, working as an assistant professor at LG Institute of Physiotherapy. Our topic for today is F-wave. F-wave is one of the late responses that we record for diagnostic purposes of the peripheral nerves in nerve conduction velocity studies. F-wave result from antidromic activation of motor neurons involving the conduction to and fro from the spinal cord occurring at the interface between the peripheral and central nervous system. Now, why it is called antidromic activation of motor neurons? Antidromic activation is always the direction against the physiological direction, or you can say the direction of conduction is opposite to that of physiological direction. That is why we call it antidromic activation of the motor neurons, right? Because for the physiological direction of the motor neurons in F wave, the direction is opposite of that of physiological direction for motor neurons. That is why it is known as antidromic direction. Okay, in this diagram you will be able to see. Now, as you can see here, the F wave is elicited here, right? F wave. So what happens? For activation of F wave, we always need a supramaximal stimulus. Okay, a supramaximal stimulus is given at the peripheral nerve. So this peripheral nerve is stimulated at the distal side. So what happens? Remember one thing, in F wave the direction of propagation is in both the directions, right? Towards the spinal cord and then coming back from the spinal cord, but it does not form a reflex arc. Okay, so in F wave we stimulate the distal side, right? We stimulate the distal side, leading to propagation of impulses in both the directions. See, in this diagram you can see these arrows. See, this is one direction and this is the another direction. Now the orthodromic impulses travels to the distal muscles. Okay, you can see here, this is the orthodromic impulses that is traveling to the distal muscle, and the antidromic impulses that travels away from the muscles to the spinal cord, towards the anterior horn of the spinal cord. Once it reaches the anterior horn of the spinal cord, there occurs a series of events, right? So the first event is as it reaches the anterior horn cells of the spinal cord, there is depolarization of the axon hillock. Once the depolarization of axon hillock then leads to depolarization of dendrites. From here, then from the depolarization of the dendrites, the direction is then again reversed to the depolarization of the axon hillock. Once this direction is reversed from the depolarization of axon hillock, there generates an orthodromic impulses that goes back to the muscle, right? There is no synapse involved, so it is not a reflex as H reflex. Okay, see, in this diagram you can see this is how the F wave appear on your computer screen of the software which has NCV, the NCV instrument. On the screen the F wave appears like this. Now, stimulation. F wave can be recorded from any distal muscle by stimulating any appropriate nerve. The conventional supramaximum stimulation is 25% above. See, maximal stimulation and 25% above that maximal stimulation is known as supramaximal stimulation. And the frequency is, or the rate you can say, is not more than 0.5 hertz. Why? Because the rate is kept at a particular fixed numerical value to prevent any overlapping responses from the previous stimulation. Okay, so the recording electrode is similar as in nerve conduction study, is placed on the belly of the muscle. Then the amplifier is set at 200 to 500 microvolt per division. The sweep speed is 5 to 10 milliseconds. The F wave recording is done from a relaxed muscle. Okay, for a proper interpretation for clinical purpose, we at least take 10 to 20 F wave responses are elicited. Now, there are properties of F wave. First is the latency. Now, what is latency? Latency is the first positive or negative deflection that we see after the stimulus artifact. The first positive, the time duration when the stimulus is given, then there is a time duration, there is a blank line, there is a time duration after which there is either a positive or a negative deflection. Okay, so in upper extremity, the F wave responses, the latency is 25 to 32 milliseconds. For lower limb, it is about 45 to 56 milliseconds. Crono dispersion is whenever you take successive F waves, you will be having a maximum latency and a minimum latency. So the difference in the between the maximum latency and the minimum latency is known as Crono dispersion. Okay. Then amplitude is actually a small compound muscle action potential which represent 1 to 5% of the muscle fiber. Persistency is how persistent the F waves are, and it is usually 80 to 100%. It should be above 50% in normal individuals. Now, F wave estimate is generally for distal motor latency. F wave estimate, why we take into consideration, is to rule out any false positive or false negative results. Sometimes because of for example, some physiological factors such as height of the person. Okay, so for height of the person, the values may not match to the pre-decided values. So we take F wave estimate to rule out such conditions. Okay, then now we will be seeing the clinical application. See, as you can see, the latency is the most important or the most sensitive measures in polyneuropathy. As you can see, the F waves are there is a prominent slowing of F waves in GBS. F wave is a gold standard diagnostic measure in patients with GBS. You can see here, this is how the GBS, this is the normal or the recovery, and this is how the curve in the patients with GBS is seen. Okay, so F wave will give us an idea about the demyelination of the proximal nerve segments, okay, which cannot be measured by a regular nerve conduction study. Now, there are certain things like presence of F waves in presence of normal distal motor conduction suggests that if the distal motor conduction is normal and you have F wave presence of F waves, that will indicate there is a proximal nerve lesion or there is a nerve root lesion. Okay, so this is what are the points to be considered, which, see, F wave leads to an early diagnosis. There is a possibility that abnormalities in nerve conduction study may appear in the later stages, but F wave will give us a quick and a faster diagnosis when the distal motor conduction latencies are still normal. Okay, so Crono dispersion of the F waves may be increased in demyelinating neuropathies. That is again a diagnostic measure. Then in CNS lesion, there is a decrease in F wave amplitude and persistence that we can see in upper motor neuron lesions, and we can correlate it with hyporeflexia or hypotonia, where the F wave amplitude and persistence and FM ratio are increased in the chronic stage. F wave latency may be prolonged while the duration and amplitude may be increased now in upper motor neuron lesion. These are the research studies that have presented with such findings. The latency is useful in peripheral nerve root lesion. The FM amplitude ratios are increased. See, the FM amplitude is the amplitude ratio between your F wave and M wave. Okay, F wave and M wave amplitude ratios are increased both in peripheral neuropathy as well as in the spasticity. So we need to clinically correlate in such conditions. So this was all about F wave. Thank you.